Hi everyone, thanks again for joining us for Reporting with the Legends. And once again, we've got the legend himself, Faraz, who's going to be helping us go through a case of someone with a pericardial effusion. And we're just going to talk about tamponade for the next 10 minutes or so.
G'day, guys.
Faraz, okay, classic first view that we've got. Tell me how you're going to differentiate pericardial effusion from pleural effusion.
Okay, so I think what you look for is the pericardial reflection and the descending thoracic aorta. So here, I mean, it's a lot easier because it's predominantly an anterior effusion over the right ventricle, which you can see at the top of your screen.
Yeah.
At the bottom, you can see that it's within the pericardial reflection, and you can see the reverberation artifacts caused by the pericardial effusion running through and the descending aorta behind them. So you can be confident that this is a pericardial effusion and not a pleural effusion.
Nice. Okay, next question would be the size. So I know I've read the books. They tell me that to measure the size of the pericardial effusion, I've got to measure it end diastole in the greatest area possible, and that's sort of perpendicular to the heart. Does that sound about right?
I think that's completely fair. And this is where you find that CTs can often overcall the size of effusions because they're tangential, non-echo planar cuts. So we often get referrals for large effusions, which end up being small to moderate in size when you actually put an echo probe on them.
Yeah, nice.
Having said this, perpendicular to the heart, this does look like a large effusion with something quite concerning, which we'll obviously come to.
Yeah, nice. So to measure, I'd go stop. Oh, I'm going to stop. I'll try and find if I can grab it properly. No, not like that. So I'm trying to find end diastole. So just when the mitral valve closes, and then I'd measure it in the largest portion. And so if I was making a measurement like that, would you consider that to be okay, or would it be?
Well, I guess the question is, where is the largest size of the effusion, which would be out there, and also in other views. So, you know, we can have loculated effusions, which may be posteriorly based and laterally. So in all of your echocardiographic views to get an answer, keeping in mind, it's hard to be perpendicular to the long axis of the heart. In apical views, it's not possible. So ideally in a short axis or parasternal long axis plane.
Nice, absolutely, because that's when we're doing axial rather than lateral resolution.
You can also do it in a subcostal plane because again, you end up being parallel in a subcostal long axis view. You can be perpendicular to the long axis of the heart.
Yeah. All right. Okay, so let's get on to talk about the features of tamponade. So first and foremost, tamponade is a clinical diagnosis, right? And this is a lady who is 70 years old. She's got a background of having a kidney transplant in 2001. She's end-stage kidney disease now on peritoneal dialysis. She's got some hypertension. She's had a history of GORD, lymphedema, hernias, and got a fistula in her left arm. So we're thinking it might be a uremic effusion. She's come in with a 10-day history of increasing shortness of breath, worse on lying flat. She's had an unintentional 10-kilogram weight loss, which then starts putting into question, is this actually uremic or could this be related to a neoplastic disease, right? So, but the things that grab me on that, the big things for me is clinically, she's got shortness of breath. That is one of the big features for me of someone in tamponade, worse on lying down flat. I am thinking that if this is any kind of effusion there, this could be playing a significant role. Does that sound?
I think so. I think a couple of points here. Dyspnea is the most common symptom of tamponade. So when we try to explain it away by saying they're not hypotensive, that's a hemodynamic manifestation, but one of the earlier manifestations is going to be dyspnea. So that's important. I think uremic pericarditis has to be considered here. But if you look at that mass bouncing around, you know, considering a malignancy would also be very, very important here. And then we're going to go into the hemodynamics of tamponade. But even in a parasternal long axis view, you've got to look at supporting features to suggest this is, you know, how bad this tamponade is. Probably the only interesting factor here is that the heart rate is 85. So in someone who was about to crash, really compensating on tamponade, I would expect a tachycardia. So that's something that doesn't fit with our entire picture. But a large effusion, what looks like an adherent mass, which personally I think may just be a fat pad, but it could be a malignant mass as well. It could be infiltrating. You can see sarcoid cases, which also have deposits such as this. So I think you have to have an open mind and proceed cautiously.
Yeah, and maybe I should say that at this stage, you know, we've. I love your comment in the last one, which is say the parasternal long axis view is can give you a lot of information, and also the one that can embarrass the person who's making the decisions about a patient. All of that can be on the parasternal long axis view. I'd be saying that I'm wanting to reach for a needle at this stage. You know, we got a lot of things that tell me I need to drain this. I need to know if this has got malignant cells in this fluid. But the important thing is to finish off the study and make sure that we go through all the things that we have to. So what would be the echo features that we'd look for tamponade? Because we talk about free wall collapses. Talk to me a little bit about that.
So I think we've got to be very specific about which chambers we're talking about first. And it tends to be the lower pressure chambers. So these are your right-sided chambers that tend to collapse first.
Yeah.
And it tends to be when the pressures are lower. So for the right ventricle, this tends to be in diastole and end diastole. So what you want to see is end diastolic collapse of the right ventricle, or even buckling. And you can use M mode to help get a better temporal resolution. And there is a feeling that right at the end, and
I can do it. So this is using something called anatomical M mode.
And this is very elegant because if you have a look at your M mode representation, you are getting buckling and compression of your right ventricle. And often you also see this in the outflow tract of the right ventricle in the parasternal long axis views as well. Similarly, for chamber collapse of the right atrium, it tends to be when those pressures are the lowest, and that is systole. So you're looking for diastolic right ventricular collapse and systolic right atrial collapse.
Nice. And just quickly to show for everyone here, so I've just put an M mode cursor down through this. So I've got the right ventricle free wall at the top of the M mode image here, and we can see it buckling underneath here, as Faraz was saying, during diastole, which is from the end of the T wave to the beginning of the QRS complex approximately. Really nice. So let's talk about the RV. So just so that was the RV. Let's talk about the RA. So what views would we look for the RA? I guess we've got the parasternal short axis view, and we've also got the apical forechamber, and we have the subcostal. So just let's use the apical forechamber here. What do you think of this?
So this is an excellent apical forechamber view. It shows you collapse of your right atrium, and right atrial collapse is an early sign because it is the lowest pressure chamber. It is a sensitive sign, but not necessarily the most specific sign. However, you can have it be more specific if it is collapsing for more than 30% of the cycle. So what you do is, if we stop it and see when it's collapsing, ideally what you would anticipate is in systole, which is what we predicted, and it looks to be more than 30% duration, which would suggest that, which would correlate with more severe intrapericardial pressures, which are causing the compression.
Nice. Because you can get LV and LA pressure, but those are much less common in the lower pressure chambers, the right side.
And I think for critical care doctors, where that becomes relevant is post-cardiothoracic surgery, where you get loculated diffusions and collapse of isolated chambers, basically. So that's something to be mindful of. And particularly post-surgery, if you're not getting good views, low threshold to pop the toe probe down and have a walk.
Nice. Okay, so we talked about the clinical signs. We talked about the 2D features with particularly the RV and the RA free wall collapse. Let's move on to talk a little bit about Doppler. So, and the Doppler, I'm afraid I've only got one of these images, but we talk about a change in flow variation across the mitral valve and across the tricuspid valve. I've read different reports in different guidelines saying what it is. I use about 45% for the tricuspid valve and about 25% for the mitral valve. What do you use?
So look, I think I'm there with the same numbers. I generally use 40%. I've read as high as up to 60%, but I tend to use the 40% cutoff for the tricuspid. So 40, 45, I think we're being arbitrary. The mitral valve, I use 25%. One word of caution I urge is to get a stable image and actually look at it in inspiration and expiration, because what you don't want to do is have probe misalignment to the inflow jet, causing a pseudo changing of flow. So once you've done that and you know that your image is fixed and you're getting appropriate inflow measurements without too much angle offset, then you can use this. And what Sam, you've got here is the respirometer, and it's important that as the wave is going up on the respirometer, you're inspiring, and then it's coming down, you're expiring. So to be very specific with that, and then measure the peak velocity. And more often than not in tamponade, you've got a fusion of your ENA waves, which is why you get a single peak. And you've also increased your sweep, decreased your sweep speed, so to crunch them all in. That allows you to measure it. Now,
so these measurements, do you think that'd be okay? I guess this patient's breathing pretty quickly, it looks like here, which again kind of fits with maybe there's some tamponade physiology. And we'd have, I mean, it's It's not exactly
I don't know if
25%,
it's
though,
quite
is it?
25%, but
No.
one of the confounding features, and if we can bring up the view here, is we've got a dysfunctional LV. So a lot of these signs are obviously
Look at the
described in people
size of
with
it.
a good LV, but if you've got a big dilated LV, then your LV EDPs are already very high, and you may have fixed elevated left atrial pressures, meaning that respiration may not modulate it to the degree you'd expect it to in people with less of a restricted filling profile.
And maybe we could also the same say about the RV free wall collapse. If you've got significant pulmonary hypertension, which I don't think this patient does have, but if you did have it, you sometimes don't get that RV free wall collapse either, but you can still have issues with obstructive flow. Awesome. All right, let's talk about, so I think we'd have clinical features with this patient that fitted with tamponade. We've now got echo evidence that backs it up in terms of free wall collapse. We haven't seen a bouncing septum, and sometimes we can see that. And that's because we've got raised left ventricle and diastolic pressures. I think we need to drain this effusion.
And Sam, probably the last thing is, just to be specific, is expiratory increase in E-wave velocities in the left ventricle, and inspiratory increase in, and this is describing an exaggerated version of ventricular interdependence. That happens all the time, but when you've got fixed elevated intrapericardial pressures, then the septum bounce is exaggerated. So I think here, because of the LV being dilated and cardiomyopathic, we've got essentially two coexistent properties which are causing the patient to be a lot more short of breath.
Fascinating. All right, so I might just show this picture here because I think it's pretty cool. So when I drain effusions, I try and use the echo to try and tell me where the biggest amount of fluid is and where the safest place to put it in. So to have the minimal amount of room for error. And I've been increasingly using the apical view. I have seen that's not a view that I'd recommend people to do if they've never done one before. It can be very treacherous because you've got the LAD that can be down there, you've got the LV there. You do not want your needle anywhere near either of those, and that can absolutely kill patients. The safest approach is under the xiphoid, but you have to go through a lot of liver to get there. It's often a bit further. I sometimes find the drain gets stuck in the diaphragm in younger people. And that's why I look more to the apical approach, but recommend doing that with someone who's done it before you have a crack at it. But often when I'm doing that, I then do, as I'm doing, to check them in the right space, I do this, where I take a little bit of the fluid out, a little bit of air, and I squirt it back in with someone else doing an echo. Here from the parasternal view, someone's doing an echo while I was at the apical view. And this tells me that I'm in the right spot. Do you use this technique?
I inject the line a lot.
Yeah, cool.
I've also used Diffusion as contrast because it's much more echogenic. But it helps you to know that you're not in the right ventricle.
Yeah. And then we can see someone post drain insertion. The fluid looks much less. I think we're seeing less collapse of some of those free walls. It's not perfect, and obviously just takes a little while to drain everything out.
The other caution, and this is very interesting, is often when you drain pericardial effusions or you treat pericarditis with an effusion, you can get transient constriction physiology because you've got thick angry adherent pericardium that tacks back. Usually this tends to reverse, and if you follow them up, that gets better. But early on, you wouldn't be surprised if you start getting those hallmarks such as annulus reversus, annulus paradoxus, and think that you may have made things worse, but usually tends to get better. This is one of the reasons where with prednisone, if you acutely reduce something and you really tack it back, which is sticky like glue, you can have an increased risk for future constrictive pericarditis, but something not to be surprised if you see.
Fantastic. Faraz, thank you as always.
No, thanks for having
see you
me,
next
Pat.
time. Thanks very much.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.